Morning all, respected judges, presenting my study on topic proportion on dyslipidemia in patients with Meibomian gland dysfunction in a tertiary care center. Meibomian gland dysfunction is one of the most common ocular surface disorder and a major contributor to evaporative dry eye disease. Changes in systemic lipid metabolism may alter meibum composition, increases its viscosity, and raising the melting point, thereby leading to glandular obstruction and progression of MGD. Understanding the relationship between both may help in identifying dyslipidemia as a modifiable risk factor for MGD and provide new insight into preventive and therapeutic strategies. Screening for dyslipidemia in patients diagnosed with MGD allows for early detection and intervention, potentially improving both systemic and ocular health outcomes. The primary aim of my study is to estimate the proportion of dyslipidemia in patients presenting with Meibomian gland dysfunction in OPD, and secondary objectives were to determine the association between MGD and individual parameters of fasting lipid profile, to assess the effect of dyslipidemia on severity of MGD, to identify whether treating dyslipidemia causes improvement in MGD. The study population include patients of age group 45 to 75 years attending OPD, and the study design was a cross-sectional analytical study with convenient sampling of duration 1.5 years with sample size of 50 patients. And the inclusion criteria include all patients presenting with MGD and not on any lipid lowering agent. Exclusion criteria were patients using medications which cause dry eye like tricyclic antidepressants, antihistamines, diuretics, beta blockers, patients on anti-glaucoma medications, patients with rheumatoid arthritis, Sjogren's, lupus, and patients with history of previous ocular trauma and ocular surgeries. Study variables were age distribution, gender distribution, slit lamp examination and staging of MGD, shimmer test, tear film breakup time test, fasting lipid profile including all individual parameters, and post-treatment improvement in symptoms. Coming to result, comparing age and clinical stages of MGD, higher number of MGD cases were seen between 60 to 70 years of age group, but the relation was not statistically significant, but age remained as a background risk factor, but does not independently determine disease severity in this data. Comparing gender and MGD severity, both genders were affected similarly across all clinical stages, but gender was not an independent factor influencing the severity of MGD. Comparing the total cholesterol level and severity of MGD, 64% of the participants had high level of total cholesterol, suggesting that most of the participants in this research had elevated cholesterol, which may be linked to severity of MGD. And a statistically significant association was found between total cholesterol level and severity of MGD. As the total cholesterol level increased, MGD severity also progressed, with all stage 4 MGD patients having high cholesterol levels. Comparing LDL and MGD severity, 58% of our participants had high LDL level, indicating a significant proportion of the study population had elevated LDL cholesterol, but the p-value was suggest a borderline statistical significance. Maybe larger sample size may show stronger significance. Comparing triglyceride and MGD, 76% of participants had normal triglyceride level, and the data was not statistically significant. HDL and VLDL also showed no statistical significant correlation with the study. Comparing the tear film breakup time, it was abnormal in all study participants, including tear film instability across all MGD stages, and the shimmer test also showed a decline in its value with increasing MGD severity. Conclusion: the study demonstrated a high prevalence of dyslipidemia among patients with Meibomian gland dysfunction, with total cholesterol showing statistically significant association with increasing MGD severity. Elevated LDL level also showed borderline relationship, whereas triglycerides, HDL, and VLDL do not correlate with severity. Age and gender were not significant contributors. Hence, my study suggests that systemic lipid abnormalities, particularly hypercholesteremia, play an important role in pathogenesis and progression of MGD. Therefore, routine lipid profile screening in MGD patient is recommended, as early detection and management of dyslipidemia may help improve both ocular surface health and overall systemic outcome. Further, longitudinal studies are needed to establish causality and assess the benefit of lipid lowering therapy in MGD management. The limitations of my study were small sample size, the cross-sectional study design, and a single standard study which may introduce selection bias and limitation of applicability to broader population. And the diagnosis and staging of MGD were based on clinical examination rather than advanced imaging techniques like meibomography. And the duration of follow-up was very short, and the study did not evaluate long-term effect of lipid profile management on MGD. Since the study duration was limited, it was difficult to study the effect of lipid lowering agent on reducing severity of MGD. These are my references. Thank you.
This is a good idea. It's a good thought process. But how will you explain the pathogenesis? How hyperlipidemia or dyslipidemia causes meibomian dysfunction?
Madam, Mebum contains cholesterol esters, triglycerides, lipoproteins, etc. So, if there is increase in systemic lipids, it can alter the lipid. Meibomian glands are also lipid synthesizing organs, so it can alter the lipid composition of mebum. So, if there are increase in cholesterol esters, there will be increase in viscosity, and the melting point of mebum will get elevated. So, there will be clogging of glands. But if LDL are elevated, it have more inflammation to the gland. If triglycerides also affect the metabolism of lipids, so individual parameters affect differently. So, if we are
Different
comparing the
mechanism.
individual parameters, the treatment can be more specific, and we can consider more than an ocular condition. We can consider it as a systemic condition. So, we can correct the systemic profiles also. So, it will be more benefit for the patient. Usually, MGDs are very difficult to treat, especially in older age group.
Yes, every second patient we see in the OPD has MGD. Every third patient has got dyslipidemia. So that's what I how to correlate. Okay.
Denise, every fifth patient in the OPD also is on statins. So statins have become universal today. So that is a confusion whether that lipids have just a relation with this, whether it's just a relation or it's a causality as you stated in
With
your
advanced technique, we
your
can identify that
yeah.
we
So
need to.
that causality once you establish, then you will have strong base to say that this is this, and then you can say like LDL is this, HDL is this, that kind of looking into the deeper aspects of lipids.
If we have the facility to identify the individual parameters like mebum LDL, mebum cholesterol level, and if we are able to correlate it with systemic cholesterol
Correct.
levels, it
Correct.
will be more. But biochemistry did not have that facility for
Correct.
that.
And you'll also need to say that once with the lipids getting controlled by medications in the systemic side, this MGD also comes down. That kind of relationship also you have to establish.
There are a lot of patients with MGD with lipid profile being completely normal. So you cannot blame this that this is the one cause for MGD. Just like we are telling ARCUS, juvenile ARCUS, it is due to lipid profile defect.
One
So,
cause among multiple factors.
yeah, maybe a predisposition. We like to correlate. Okay, thank you.